been working around the clock.
Was that?
And then it's condo in Gulf Shores.
A condo in Gulf Shores with an indoor pool?
Yes, Western.
Yeah.
It's not condo.
Yeah, okay.
So turkeys?
No, we got always
You got a full house.
never allowed.
Keep people on their toes.
Testing.
Yeah, you're good.
You wanna go ahead and get started?
Just introduce yourself.
May have to be
Yeah.
a little bit loud at first to get their attention.
No problem.
If you start drifting, I'll kind of point you back over.
Well, good afternoon. I'm Ken Sagg from the University of Alabama at Birmingham in the Division of Rheumatology, and in addition to my academic affiliations, I also staff the Osteoporosis Clinic. And in addition to osteoporosis, we have a clinic in gout that is another special clinical interest of mine. In my 22 years at UAB, I've had patients with a number of you in the room, and it's always a pleasure to have a chance to come back over and talk about one of the topics of great personal and, I know, community interest insofar as the burden of osteoporosis is growing. So I want to, here's some relevant disclosures. And I want to spend some time today talking about what's happening, giving you an update on what's been going on in the bone field in osteoporosis. And there's been quite a few contentious issues that really have constituted some challenges in trying to do a better job in preventing fractures and treating people after fractures for secondary prevention. I'll talk about the therapies that are listed here, and be delighted at the end to answer any questions you might have in any difficult patients you've been seeing. So one of the things that has certainly stimulated our interest in discussing this more is the recognition that there's a bit of a crisis in the field, and that as this Above the Fold article in the New York Times suggested, that many people are missing out on an opportunity to get treated. And these are people that have already fractured, so this really is the low-hanging fruit, if you will. And that many groups, including the Bone and Mineral Research Society, the National Osteoporosis Foundation, have all recognized a need for us to collectively do a better job in this space. So this is the crisis, and you can see that if you look back in the mid-2000s, we had a peak in the use of the bisphosphonates, our most commonly prescribed group of therapies in osteoporosis. And now, in the last 10 years, and this continues actually with some newer Medicare data that we've looked at recently, we've roughly halved our prescriptions of these bone-specific therapies. And here's some numbers that are even more disturbing, and that is after somebody breaks a bone, after a person has had a major osteoporotic fracture, defined as a fracture with minimal trauma, a fall from standing height or less leading to a broken bone, the numbers of people that are getting identified and treated are actually diminishing, and it's down as low as 20%. So this is really a failure collectively, again, of our mission to identify and treat these people appropriately. Now this is ecologic data, and be careful when looking at these sorts of temporal trends because it's not personal level data and there can be some fallacies in interpreting this, but it suggests to us that while we were real pleased to see that over the beginning of the 2000s, hip fracture rates were declining, that seems to now have plateaued. And if you look at what the trend would have been, it actually would have been going down a little bit further. And this coincides with a decrease in testing associated with a decline in the reimbursement rates for bone density, a decrease in people being diagnosed with osteoporosis, and the coinciding reduction in pharmacotherapies. Now, whether this is causal or not, whether these decreases in our recognition and management of osteoporosis associates with this plateauing of the fracture rate is unclear, but it certainly is speculative and rather concerning. Another piece of information that is important, and this ties back to that slide showing that only 20% of people after a fracture are getting identified and treated, is that your risk of having a subsequent fracture event is greater in the first year. That's really the window of opportunity to intervene, and you can see in this very large study out of an Iceland registry that you never get back to the background rate of fractures after you've had an initial fracture, and particularly in that first year or two, your rate is much greater. So this is really the time when we want to try to intervene and prevent future fractures. So let me start off with a patient who will be very familiar to many in the room. This is an 80-year-old woman. She's had height loss. When people lose more than an inch or an inch and a half of height, we worry about the possibility of occult compression fractures in the spine. She's lost 2 inches. She's also had a wrist fracture, which is another one of the fragility fractures that can be a harbinger of the diagnosis of osteoporosis. Her past medical history is not all that terribly notable. High-dose proton pump inhibitors may also associate with lower bone density. There's a positive family history, and like many people these days, she's indoor a lot. She happens to be lactose intolerant and doesn't exercise. So she has a number of modifiable factors, including her diminished physical activity, the proton pump inhibitor, although not something we normally would make an adjustment around if there wasn't some other reason to attenuate the use of that therapy, and calcium and vitamin D. I want to start off with that. Now, when you gave a talk on osteoporosis in years past, the least contentious thing you could talk about was calcium and vitamin D, but there's been some questions and concerns. Around calcium, how much? How much do we need? Does it cause heart disease? If you're going to take it, is it better to get it from the diet or as supplements? And if supplements, what types should we consider? These were guidances from the Institute of Medicine back over 10 years ago now. They'd actually decreased the recommendation for the oldest adults from 1,500 to 1,200 milligrams and slightly increased recommendations for younger adults and for kids. And this meta-analysis highlights one of the reasons that we should be potentially concerned about overzealous use of calcium, and that is this potential association with cardiovascular adverse outcomes. If you look in the upper left-hand panel, you can see about a 1.3-fold increased risk of myocardial infarctions. And if you look at the other 3 panels, while the trend is consistent, the point estimate is no longer significant. It crosses 1. The numbers are not large enough to conclude the same thing. Now, this study has some limitations. None of these studies that were included in the meta-analysis had a primary cardiovascular outcome. The endpoints were not adjudicated. We don't know about kidney function. People that have bad kidneys are more likely to have bone-related health issues. And we don't use calcium alone. We give it in combination with other things. Ultimately, as in any meta-analysis, you need to think about what studies are driving the conclusions and consider a sensitivity analysis and see whether that alters the conclusion. This was a study that had a primary cardiovascular endpoint. And in this study, if anything, it looked like the use of calcium could be potentially cardioprotective. There was not an increased risk, particularly among this higher risk group, the people that had had previous atherosclerotic vascular disease. A large study out of Europe, out of Germany, suggested that it was supplements that actually increased the risk, not the use of calcium in the diet through food products. And this was a synthesis of the evidence developed by colleagues at the National Osteoporosis Foundation, suggesting that if you don't exceed the upper level of intake, there's no causal relationship with cardiovascular outcomes in this analysis. Calcium can have other adverse health effects, as suggested in this paper published in another high visibility journal looking at data from the National Health and Nutrition Examination Study and showing the increase in cancer deaths. So while calcium is an essential ingredient for bone health, we have to make sure people are getting enough if they're deficient in their diet, potentially providing supplements. Too much is not necessarily better, and given some of these analyses, it would suggest to us that we exercise some caution in many of our worried well who are over using calcium supplementation. So now that things are all clear with calcium, let's talk about vitamin D. And what about vitamin D? How do you provide vitamin D? When should we measure it? What's the optimal target? Does it have other health benefits? In the Women's Health Initiative, there was an increase in kidney stones. Here's the IOM recommendations around vitamin D. And you can see that for older women in particular, 800 IUs, the equivalent of what you'd get in a multivitamin, is what we want people to try to get each day to assure that they have an adequate level. Now, not everybody was very happy with this Institute of Medicine report. These are two advocates for vitamin D, Bob Heaney and Mike Hollick, and they said we've avoided a mind-numbing list of the number of inaccuracies in this report, and we suggest that it be interpreted with a grain of salt, another nutrient that the IOM finds risky. An updated U.S. Preventive Services Task Force told us that if you're using vitamin D for primary prevention, not people that have osteoporosis or that have had fractures, the data is insufficient to suggest that widespread supplementation with vitamin D is helpful, and that there's no benefits of lower doses. Vitamin D is not useful to prevent falls. Or rather is useful, I should say, to prevent falls in older adults. That was one of the conclusions that had come out of earlier studies, and that we don't apply these recommendations, again, to women that are at higher risk. This is more recent data looking at a large study out of Canada and showing that too much vitamin D not only may have adverse consequences, but it might also lead to a greater risk of fracturing at doses exceeding 4,000 IUs per day. The VITAL study is one of the largest studies to explore the safety and efficacy of vitamin D, and you can see the very significant sample size of this study. You can also see that in terms of invasive cancer on the right and major cardiovascular events, there was no protective effect of vitamin D supplementation. Recent data presented out of VITAL also showed that there was, and again in a primary prevention mode, no benefit to bone health with vitamin D. So that's a little bit of the data. Let me try to summarize where I think we are overall. First, you've got to have adequate calcium and vitamin D for bone health. There's really not a lot of question about that. There may be other bone benefits, particularly to fall risk prevention. If you're not deficient, or if you use an inadequate dose, you're not going to get a benefit. And similarly, this is important because I see in my clinic a lot of people who come in that are just chewing lots and lots of calcium and getting calcium with vitamin D, taking vitamin D supplements on a multivitamin, getting more than they need. Overzealous use may be deleterious. Calcium, when it's used, is best sourced from the diet. There seems to be more evidence that this is a safer, more natural way to get it. 1,200 milligrams is adequate for most adults, and that would mean that in the average American diet, you get about 600 milligrams without trying. So if you have an extra glass of milk or a yogurt serving each day, you usually will get close to the amount that you need. If you're not getting there with the diet, then providing some supplementation may be appropriate. For vitamin D, we want to avoid the dose that will be inadequate or is too high. And 800 international units, the equivalent of what you'd get in a multivitamin, is often sufficient. In terms of the level, checking a 25 hydroxy vitamin D level is the level we're interested in, and the target that's been suggested is 20 nanograms per milliliter. Now, because even with the better assays, there can be variability, we often shoot for closer to 30 to 50 in order to make sure that we're at least at 20. So back to the patient. Here's some additional data. she's got a lumbar spine bone density T-score of minus 2.8, so she's 2.8 standard deviations below peak bone mass. We define osteoporosis according to the World Health Organization as an osteoporotic person has a T-score of minus 2.5 or less at one of the major sites, the femoral neck, the total hip, or the lumbar spine. You can see she qualifies at all of her sites to meet that definition. Moreover, she's had a fragility fracture with the fracture of her wrist. So what would you choose? Here are some different options if you want to put her on a drug therapy. Lots of choices nowadays. It's great to have choices. You can take pills, you can take shots, you can take infusions, you can take something daily, weekly, monthly, once a year. So depending on issues around adherence, there's different choices that you might consider. And these different drugs have been approved in the setting of postmenopausal osteoporosis, both for prevention and for treatment, as well as for the most common drug-induced form of osteoporosis, steroid-induced osteoporosis, and many have also been indicated now for men. Here's another patient, another very common problem. A 75-year-old woman treated with alendronate. And I should go back and just say that I think what you might choose in this first patient really is going to depend a little bit on her preference and having a discussion with her around what she wants to do. We tend to use a lot of intravenous bisphosphonates. The reason being that they're safe, they're easy to use, you take a shot, you're good for a full year. You might consider an oral bisphosphonate as the standard of care, a very low cost, commonly used drug such as alendronate once a week, risidronate. You might consider abandronate every month. In this patient who's not having active fractures, I probably would not move to one of the osteoanabolic drugs like teriparatide, abaloparatide, or the newer monoclonal antibody called romosozumab. I'll talk about those in a minute. So I would think about one of those, and I might add denosumab as another possible therapeutic option given as a shot every 6 months. So let me talk about this woman who has osteoporosis by her bone density. And she's not taken estrogen in the past. She's had a history of breast cancer, which if she'd been on aromatase inhibitors would put her at greater risk. The fact that she's not had radiation is important because that radiation is a contraindication for drugs like teriparatide and abaloparatide that I'll talk more about. And she comes back to see you now 5 years later, has not had any interval fractures. Her bone density looks slightly better. We check markers of bone remodeling, which suggests that she's been getting her medicine and it's been doing its desired thing by suppressing bone turnover, as bisphosphonates should do. And she's worried about the terrible side effects of alendronate and wants your advice about whether she should continue it or should she stop it. So here's some choices. You could continue it. You might switch her to one of these other drugs. Or you could stop all of her therapies now. What does the evidence tell us? And why would we even consider this? So bisphosphonates are a very interesting group of therapies. They really have properties that don't mimic too many other drugs that we use in medicine. They're analogs of pyrophosphate. They bind into the bone. They live in the bone in the hydroxyapatite matrix. And they inhibit osteoclast-mediated bone resorption through direct toxic effects on osteoclasts and osteoclast precursors. You look at where they go. Much gets excreted in the urine. They're not particularly well absorbed orally. Some lives in the cancellous bone, but the majority of the drug lives in the cortical bone. And you can see that, curiously, and different from really nearly every other drug that we use, over time you build a store of bisphosphonates up in your bone where it's deposited. So if you were to discontinue her alendronate after 10 years of therapy, you'd see this very slow exponential loss of the drug. And after a 10-year period of 70 milligrams a week of alendronate, you'd continue to have an estimated skeletal release of 2.5 milligrams per day. So this is a very unusual drug in that it stays in bone, and even after you stop it, you continue to have some biologic activity as the bone remodels and the drug becomes uncovered. And that's reflected in this study data. This is from the long-term extension of the original alendronate study. And what you can see here is that early on, people were randomized to either alendronate or placebo. After the first phase of the study, all the people were re-randomized either to continue on alendronate, shown up here, or to just, if they'd been on alendronate, these are all the people that started initially, to go on to placebo. And one of the things that's interesting to note is that those who switch over to placebo maintain their bone mineral density at the spine. So you don't see a rapid loss of bone density at the spine. Compare that in a minute with some of the data I'm going to show you with denosumab and some of the other drugs that we use. You do see a greater increase in the bone density with the people who were re-randomized to get alendronate, but 3.7% over a 5-year period is not all that great. So the fact that the drug stays in the bone, lives in the bone, even after you stop it, is one of the reasons that you might consider stopping it. The other reasons that you might consider stopping a drug like alendronate are these side effects, the concerns that have arisen around some toxicity, if you will, to the bisphosphonates, both orally and intravenously. And osteonecrosis of the jaw and atypical femoral fractures are the two that have generated the greatest concern. So ONJ, osteonecrosis of the jaw. How many have seen or been involved in a case of ONJ? People see this in their practice? Okay. And so it's an area of bare alveolar bone in the absence of any past radiation to the jaw. It's very uncommon in the setting of osteoporosis, but if you look at people that get bisphosphonates for malignancy, where it used to be the oncologists were giving it every month or so, you would see a rate approaching 10% in some of the large series out of MD Anderson. But here we're looking at a rate of less than 1 in 1,000. Generally, this is not a big deal. And this is a patient of mine over on the far right lower panel who had this little area of bare alveolar bone over her troiolopsis palati. The dentist curetted that off. It healed up fine, no big deal. On the other hand, this is a very serious problem. This is a person that had a pathologic fracture of their jaw in the setting of ONJ, and they developed a fistula tract associated with this. So what can we do to try to prevent this, and what are some of the strategies that you might want to consider? Prior to starting somebody on a medicine like alendronate, it's important to think about dental hygiene and to get any bad teeth out, to make sure that the dentures are well aligned. That can all be very helpful, and this is what some of the oral surgeons have suggested. If you have a person who's been on one of these drugs who needs to have a extraction or have an implant put in, here's some suggestions. First of all, checking turnover markers are not helpful. That's one of the things that the dentists and the oral surgeons agree to at this point. There is a debate about whether it helps to stop one of these drugs. Now, I just showed you the data on how long they stick around, so you can imagine that even if you stopped it for 6 months or a year or whatever, it's going to take a long time before the bone becomes more metabolically active again. But generally, we would consider at least a 2-month break prior to doing something invasive. That doesn't include cleaning the teeth or filling the teeth or even doing a root canal. It's if you're going to create an area, an opening in the bone. These would be people in whom we'd be a little more concerned and consider some of these strategies. Now, so that's a rare problem. This is a rare problem too, but perhaps a problem that has gained a little bit more publicity and been more common, and that's an atypical femoral fracture. Why is this fracture considered atypical? First of all, because it's occurring in a subtrochanteric region of the hip. About 90% of hip fractures are through the trochanters or in the femoral head. This fracture is subtrochanteric, not a common location. It tends to occur with minimal trauma. It tends to be non-comminuted. There tends to be this transverse short oblique segment. Both cortices are involved. And importantly, prior to the development of a through-and-through fracture, you see this area over the cortex, this stress reaction laterally over the cortex, which is the harbinger for the through and through fracture to develop. And if you didn't know any better and you saw this person and they weren't on a bisphosphonate, you'd say, aha, osteomalacia. That looks like a looser zone, a Milkman fracture that was described back when we used to see more people with osteomalacia. So we're always, with all of our therapies, balancing the benefits and the risks, and these are rare events. They're probably not more than 1 in 1,000 per some of the large, well-done epidemiologic studies. The number needed to treat with a drug like alendronate to prevent typical fractures and to prevent radiographic vertebral fractures is shown here. The number needed to harm for one of these atypical fractures is about 400. And so for each atypical or stress fracture that you cause, each femoral, atypical femoral fracture, you would have prevented 30 typical vertebral fractures and 5 typical hip fractures. So that kind of provides a little bit of a balance, doesn't it? But the problem is this is data from a clinical trial. And clinical trials don't necessarily relate to what we see in the real world. And we also know that as people continue on these drugs for a longer period of time, the rate of these rare problems goes up over time in this data from the Kaiser Health System. So what about prevention for this? This is important in that when I have a person on a bisphosphonate and they come in and they're complaining of any pain around their hip, I get imaging. I want to make sure they don't have a stress fracture, examine them, consider other more advanced imaging if the plain film is not sufficient to help detect. And you can see even on bone density, you may be able to pick up a fracture over here shown in the bone density test scout image. So the fact that these drugs are sustained in the skeleton, that there are these rare events that may associate with more protracted use of the drugs, different groups have proposed strategies around what is termed a drug holiday, taking a break from the use of bisphosphonates. So if you have a woman who's had 5 or more years of an oral or 3 or more years of an intravenous drug, then you would consider a holiday, a break from therapy. Now, if somebody's had a hip fracture or multiple other fractures during the therapy, or if their bone density continues to remain low, then you would be less inclined to take a holiday. You might switch them to a different type of therapy. Maybe you're going to use denosumab, or you might think about one of the anabolic drugs that I'll be discussing, but you wouldn't just go on to a drug holiday in that higher risk population. This was a really interesting paper that came out just a couple years ago, and it kind of turned our thinking a little bit on its head. You know, we'd moved away from this idea of treating people with osteopenia, in part because of these rare side effects that we were seeing and the fact that their absolute fracture risk is low. We want to save these drugs for when we need them the most. But then this work out of New Zealand suggested that if you give a single dose of zoledronic acid every 18 months, you might actually prevent clinical fractures, even among women who were just osteopenic. And so that is an interesting bit of data. The other thing to keep in mind with IV bisphosphonates is the acute phase reaction. And in clinical trials, it was relatively low. We only saw it in maybe 10 or 15%. In real-world practice, it's closer to 1/3 or even 40% of people developing achiness, low-grade fevers, even rarely flu-like illness after the infusion of an intravenous bisphosphonate like zoledronic acid. Now, it tends to occur less frequently as you go on, and it tends to occur less frequently in people that have previously received a oral bisphosphonate or another potent anti-resorptive drug. But this is something your patient should be aware of if they're going to get this, and I always caution them about this. The other caveat is that wouldn't it be great if after a hip fracture, as was done in one of the large studies published by Ken Lyles in the New England Journal a few years back, that you gave zoledronic acid during the post-operative period. Here's your perfect moment. Patient's in the hospital. They've had a hip fracture. You know they're at great risk for another fracture, as the data we saw suggested. The problem is this acute phase reaction. You really don't want people post-op developing fevers and having these symptoms. That can be very confusing after they've had a pinning or a hip arthroplasty, for example. And so when we do use this acutely, we tend to wait at least a few weeks after the event. Sometimes if they're going to be in rehab, that may be an opportunity to consider such a therapy. So that's an update on bisphosphonates. I want to turn now to a couple of other therapies. Here's some data with denosumab showing that it continues to have benefits even beyond the first few years. In contrast to bisphosphonates, we don't see the plateauing in bone mineral density gain with denosumab, which is a monoclonal antibody to rank ligand. So it affects the crosstalk between bone cells, and it's shown to reduce fractures at both the spine and at non-vertebral sites as well. One of the issues, in contrast to the bisphosphonates with denosumab, is that when you stop it, it goes away very quickly. The effects recede very quickly. And here you can see the decline in bone mineral density when a patient has come off of denosumab. And if you look at on treatment, comparing the blue bars, you see that denosumab had a significant reduced risk of fractures compared with placebo, but off treatment, the rates look similar, and if anything, for multiple fractures, the rate may actually be higher. So this is a rebound phenomenon with denosumab that has caused us to be a little bit concerned about stopping it abruptly. So you don't take a drug holiday after denosumab. You have to have an exit strategy and think about something else that you might do. If you give a dose of zoledronic acid immediately at the time that your next denosumab dose would be due, and we give denosumab as a shot every 6 months, you can see that that doesn't necessarily protect against the rate of bone loss. So there's still some protracted effect. In contrast, if you look at data, these are small numbers arguably, but if you look at data about what happened if you waited up to 2 months afterwards, you could actually sustain some bone density benefit, which looked similar or better than giving risidronate after denosumab. And so that led this editorial writer to suggest that when you stop denosumab, you might consider starting an oral bisphosphonate right at the time when your next dose would be due, or if you're going to use an intravenous drug, that you wait 2 to 3 months after the next dose of denosumab would be due to administer that IV bisphosphonate then. Could you switch somebody to teriparatide, which is a bone anabolic drug? We know that if you give teriparatide, which stimulates bone formation, you always want to follow it with an anti-resorptive drug like a bisphosphonate or denosumab afterwards. And that leads to some consolidation of the gains in bone density, filling in the new remodeling space that's been created. On the other hand, if you switch somebody from denosumab to teriparatide, you'll actually see some decline in bone density early on. So the anabolic drug that stimulates bone formation doesn't work as well immediately after a potent anti-resorptive drug like denosumab. Well, I've talked a little bit about these anabolic approaches, and I want to spend a few minutes on these because this is really where there's a little bit of newer data. Teriparatide is the one that's been around the longest. We have now nearly 15 years of experience with it, and it's really a drug that is generally very well tolerated. It's given as a shot daily for up to 2 years. And we finally have now a study that compares people with teriparatide with the bisphosphonate risidronate, and you can see that there was a significant risk reduction in new vertebral fractures comparing teriparatide with risidronate. You can see that also held up for these other endpoints of a clinical fracture and non-vertebral fragility fractures. So teriparatide for a high-risk population was significantly more efficacious than an oral bisphosphonate at preventing vertebral fractures and clinical fractures, but not non-vertebral fractures. And this was in contrast to what the American College of Physicians had suggested in their recent osteoporosis guideline, which did not include recommendations about the use of these anabolic drugs. So those of us in the bone world were delighted that the American College of Physicians put out guidelines around osteoporosis. That was great. Important that they be in this space and recognize this. They give reasonable guidance to generalists. They heighten awareness. They introduced the idea of a drug holiday, but they often didn't deal with some of the nuances that we see in the bone clinical practice. They recommended a universal drug holiday, which would include denosumab as well as these anabolic drugs like teriparatide, and that is not the way those drugs should be used. And they didn't recommend the use of anabolics at all, largely due to cost considerations, but in part because that Vero data that I just showed you, the head-to-head study, had not yet been published to show in a well-designed clinical trial comparative effectiveness. So there's a new drug out called abaloparatide. It's been available now for several years. It looks more similar to PTH-related peptide than it does to PTH. And similar to teriparatide, abbreviated as TPTD, abaloparatide, ABL, resulted in greater increases in bone density over placebo, shown down here at the bottom, and also showed a reduced risk of non-vertebral fractures compared with placebo in pink, abaloparatide in blue. It looked, if anything, better than teriparatide, although the study was not powered to show a direct comparison of those two. So these are drugs that have with them also a risk, a warning rather, that is in the product circular around osteosarcoma. In a particular type of laboratory rat, there's an increased risk of osteosarcomas that have been seen with these two drugs. And they're both efficacious and well tolerated. You'll have a little more vasodilation when you give abaloparatide, and teriparatide has a greater increase in calcium compared with abaloparatide. This osteosarcoma concern for teriparatide is not translated into a effect in clinical practice. We have not seen in large database linkages to cancer registries any increased risk of osteosarcoma, but based on a limited anabolic window as well as this potential concern, we limit the use of these drugs to a shorter period of time. And the last drug I want to talk about, and then I'm going to leave some time for questions, is the newest therapy, that's romosozumab. Romosozumab was developed based on an understanding of bone pathophysiology and the fact that sclerostin is a potent inhibitor of osteocyte-derived bone formation. Sclerostosis is a rare genetic disorder seen predominantly in Afrikaners who develop an osteopetrosis-like syndrome, and they have a deficiency of sclerostin. So what the molecular biologists have done is they've developed an inhibitor to an inhibitor, a monoclonal antibody that inhibits sclerostin, which inhibits bone formation. So by inhibiting an inhibitor, it results in a potent stimulation of bone formation, similar to what we see in sclerostosis, but not as dramatic. And here you can see in this small phase 2 clinical trial, looking at romosozumab in green, teriparatide in pink, and alendronate in blue, comparing that with placebo in white, the increases in bone density. There's nothing that results in increases in bone density quite as profoundly as does romosozumab. So very significant stimulation of bone density, both at the spine and at the total hip. This is perhaps the most important slide because it explains perhaps what's going on here and shows us how this drug is different than the drugs we're used to using. You can see that with romosozumab, this inhibitors to sclerostin, you see an initial increase in a marker of bone formation that then is transient and comes back to baseline. There's also, curiously, a slight reduction early on in a marker of bone resorption, which also then comes back to baseline. Contrast that now with the drugs we're more familiar with, teriparatide, which results in an improvement in a marker of bone formation, but is coupled to an increase in turnover at bone resorption sites. And then alendronate suppresses both resorption, its primary effect, but also has a small effect on suppressing bone formation. So this drug is behaving quite differently than our traditional bisphosphonates and also these drugs like teriparatide and abaloparatide. And the large frame study showed a reduction in fracture risk with similar to what we see with denosumab and bisphosphonates, also some events of osteonecrosis and atypical femoral fractures. And then this was a study that we did looking at a more pragmatic clinical trial design, comparing a dose of romosozumab with alendronate over 12 months, and then after 12 months everybody switched over to alendronate and there was a risk reduction in fractures, both non-vertebral fractures, vertebral fractures, and hip fractures, as you can see here in the group that was randomized to romosozumab. So it looked very good from an efficacy standpoint. The concern with this study, published now a few years ago, was this, that there was also a safety signal seen of cardiovascular adverse events, a 0.5% risk difference of myocardial infarctions and strokes with in the group that received romosozumab. Now, it's still unclear whether this was a chance finding, whether this is a real finding, whether in an active comparator study maybe alendronate was somehow cardioprotective. There's some letters to the editor that will be coming out soon in some of the bone journals that speak to this a little more, but needless to say, this has led to a black box warning around this as a risk for romosozumab and something we should be aware of when prescribing this drug, discussing this possible cardiovascular safety signal with our patients. So let me try to summarize where we are. We have a number of treatment options available. We have the bisphosphonates, the rank ligand inhibitor denosumab, which decrease resorption and to a lesser degree decrease formation. There was a development of a drug called adanicatib, but $1 billion later that drug was withdrawn from development due to a cardiovascular safety signal. We have our osteoanabolic drugs, teriparatide and abaloparatide, which stimulate formation and to a slightly lesser degree bone resorption. And we have this new drug, romosozumab, a monoclonal antibody to sclerostin, which predominantly affects bone formation, but also has a modest effect on decreasing bone resorption. The last topic is just to mention the controversies around vertebral augmentation, kyphoplasty, and vertebral plasti. And this was a recent report out of the American Society of Bone Mineral Research, which suggested that the evidence base is really quite weak, and we're not really sure in whom to do this and whether there may be an increased risk of secondary fractures. So many groups, including the NIH and the American Society of Bone and Mineral Research, have been putting out position papers around the need to be more aggressive in our management. In conclusion, calcium and vitamin D are necessary for bone health, but too much may not be optimal. For bisphosphonates, we should consider drug holidays, balancing long-term benefits and risks in selected patients. Alternate therapies such as anabolics and shorter-lasting antiresorptives may be useful for patients at high risk. And newer treatment approaches focus on potent stimulation of bone formation, although safety questions are present for the new monoclonal antibody to sclerostin romosozumab. So time didn't permit me to talk about all sorts of things around fall prevention, a topic of great importance in trying to reduce the risk of fractures. But I want to stop here, and I'd be delighted to discuss any patients with you or take any questions you might have. So thank you very much for your time and attention. Question? Yes.
So if you had a patient who had a delay in, say, her next denosumab injection, had a new possible vertebral fracture during that period, I mean, would you really classify that a treatment failure or more this Prolia discontinuation syndrome? And so then just resume denosumab and stress, the importance of the patient that she's, got to get her shot.
Yeah, yeah. Well, thank you for your question about what to do in a person who has taken denosumab, missed a dose, and then has fractures as associated with that. We won't say as a result because we don't know what would have happened had she been on the drug. None of these drugs are 100% efficacious for reducing fractures. And the question always comes up is what constitutes treatment failure? We do know about this rebound effect, and it is concerning. And when I start a patient on denosumab, I have a very deliberate discussion with them, emphasizing that if they're going to be on this drug, it's really important that we and they are attentive to when the next dose is due. And that can be a system problem too, because sometimes just getting it scheduled is not always straightforward. So in that circumstance, that particular patient who's had that fracture, you could certainly put them back on denosumab. You might consider one of these other therapeutic approaches. If they're more than a few months away from that dose, that would be a circumstance where you might think about teriparatide, abaloparatide, even romosozumab as another option. There's a little bit of data, not a lot, but a little bit of data with romosozumab after denosumab in one of the studies in which that was examined, and it looks like you don't, I showed you the data with teriparatide showing that if you give it right away after denosumab, you don't get that stimulation of bone formation because there's still some residual effects of denosumab suppressing the ability of teriparatide to stimulate bone formation. But I mean, this is a big concern, and I think we just have to be very attentive to what to do after denosumab and making sure that our patients get their shots. So thank you for that question. Good point. Any other questions? Okay, well, thank you all very much.